Let's go to another case history. We just have 15 minutes. John gave me this sign. Okay, she's 65 years old. She's got hot flashes, headaches, vaginal dryness, mood issues, weight gain, cognitive changes, increased joint pain, poor sleep, food cravings, night sweats. You know any 65-year-olds that have anything like that? Okay, so I'm often asked, well, how old is too old to have a hormone evaluation? There's no upper limit. The oldest patient I've ever prescribed hormones for was 92. And, you know, she came in for a visit. She was dressed to go to the Valentine's dance. Her legs were fantastic, and she was wearing a beautiful red dress and red pumps. And who am I to judge her judgment as it relates to what model of care she wants at age 92? So I think women are living longer. If we go back 100 years ago, the average life expectancy was 49. Now it's 84. And so a woman will live nearly half her life after menopause because the average age of menopause has not changed in several hundred years. Average age of menopause is 50. So we've got to address this, and by doing so, we may be able to minimize or prevent age-related diseases of heart disease, osteoarthritis, osteoporosis, diabetes, insulin resistance, cancer, and dementia. So her BMI is normal, waist circumference normal. She's got hormone-related symptoms, and her triglycerides and inflammatory factors are high, and her blood sugar is high. And she's on a couple of prescription meds. At this visit, she said her parents were in good health. She's been retired a couple of years, lives with her husband. She's already exercising 5 or 6 hours a week, only watching 7 hours of TV a week. Excellent. She says, I've got some decreased stamina on review of systems. So look at her hormone profile. Estrogen, non-detectable. Even with the saliva, which is very sensitive in the low analyte ranges, there's just not even enough there to measure. Her progesterone, less than 15, very, very low. Ratio, very low. Testosterone, low. DHEAS, low. Her cortisol circadian rhythm is not too bad. This is normal along the green line here. So what does she need? Well, I'm going to start with estrogen and progesterone. Because of the promiscuity of the hormones, some of them can be converted from estrogen to testosterone or from progesterone to cortisol. So I'm going to see how things settle down. And so she comes back, she's got improvement in most symptoms, but she still has a lot of musculoskeletal pain. She's also had a recent stressor of her father's death. And you can see that her hormone-related symptoms got better. We saw improvement on her lipids and her inflammatory factors and her glucose at 8 weeks. So let's look at her hormone profile. Well, she's at goal range with her estrogen and her progesterone. Her testosterone is slightly improved. The DHEAS has still stayed down there. So at this point, she's on estrogen, progesterone. I'm going to add DHEA. And her blood pressure is getting lower, so we're going to start weaning her off of her blood pressure medicine. She doesn't need it anymore. So here's her follow-up. We've now got everything in goal range, but the testosterone has declined again. So at this visit, I'm going to go ahead and add testosterone. So some of my patients are on all of those hormones. They need all of those hormones. They have documentation of low endogenous levels and symptoms related to that. So at 36 months, she comes back. She feels balanced. Her stamina, mood, and pain are improved. She has occasional hot flashes, but says these are stress-related. She's decreased her body weight and her waistline just a little bit to what she feels is normal for her, and her inflammatory factors and glucose are at goal range. And this is showing her follow-up hormone profile. So we're always following up. We're making sure we're at goal.